All right, I think we're good to go ahead and get started. So thanks everybody for joining us. Welcome to our first ever Vail Summit Orthopedics and VSON Alpine joint webinar. We're really excited to be hosting this. Hopefully we have a good amount of people coming from both Eagle and Summit, and then our Gunnison and Telluride areas as well. Hope everybody enjoys the talk tonight. So I would like to introduce myself first. I'm Rachel. I'm the Director of Marketing. I'm going to be in the background most of the time, but I'm going to be helping to manage questions as well as any follow-up emails or inquiries that come in after this event. So with that said, we will be doing a Q&A session throughout and towards the end of this event. So you can feel free to submit your questions in the chat here, or in the chat, in the Q&A section at the bottom. You can submit your questions there as well. Whatever works best for you, feel free to submit them. We're gonna try and get you as many questions as possible with the time we have. Probably gonna spend about 20 to 30 minutes on questions. And with that said, I wanna introduce Dr. Nathan Caferkey, who is our total joints specialist at Vail Summit Orthopedics and Neurosurgery, who is mainly in our main practices. And then I want to introduce Dr. Gloria Beam, who is an orthopedics and sports medicine specialist. She is the lead surgeon at VSON Alpine, and she founded that clinic back in 1999. So we're really excited to have her on board and to be teaming up with her and all the great things she has to offer. So with that said, I'm going to go ahead and let the docs take it away.
Thank you, Rachel. And it's good to see everyone tonight. I'm Dr. Nathan Caferkey, and with me is Dr. Gloria Beam. I want to let Dr. Beam go over her introduction slide here, as she is probably one of the most impressive people I've ever met. And working with her is very exciting. And anyway, I'll let her take it over from here.
Thank you, Dr. Cafferkey. Hello, everybody. It's really great to have you here, and we appreciate it. Hopefully you'll learn something really exciting, and I know you will, about total joint replacement from Dr. Cafferkey, who is amazing. He actually did my total knee about 6 weeks ago, and I'm doing awesome. But I've been here since '96. I trained back east at Columbia for 5 years, and then I did a sports medicine fellowship, shoulder and knee fellowship in Pittsburgh. And I got here in '96, and in '99, I opened up Alpine Orthopedics, and I've been serving Gunnison, Crested Butte, and Telluride since then. And I just have a wonderful population of patients from all those areas. And we also have patients traveling from all over the country, actually. So it's wonderful. I've been alone for a long time, and to be a partner with such an esteemed group of orthopedic surgeons as from Vail Summit Orthopedics and Neurosurgery is amazing. It's a dream come true, and we're going to have so much to offer this community, so much more than we could before when I was alone. It's just wonderful. And I've been taking care of WCU, or Western Colorado University, as it's called now, since I got here 25 years ago. And I love taking care of athletes at all levels, from elementary school to college and professional and Olympic sports. I've been honored to have attended 6 Olympic or Paralympic Games. I've been to both, and I'm going to be in my 7th in Beijing this March, which is very exciting. I've learned so much from traveling all over the world with teams and athletes, and I try to bring it all back here and help everybody, whether they're an athlete or not, to make their lives better and their athletics better. And that's my goal. That's my vision. So again, I'm thrilled to have the partnership with Vail Summit Orthopedics and Neurosurgery, and particularly Dr. Cafferkey. And now it's your turn, Dr. Cafferkey.
Thanks, Dr. Beam. It's a pleasure to work with you as well. So I also want to introduce myself. Some of you on this call may already know both of us, but for those of you that don't, we want to make sure that we give everyone an opportunity to ask questions throughout this talk, and specifically at the end. But again, I'm Dr. Nathan Caferkey. This is my resume here, basically, and definitely not as impressive as Dr. Beam's. But with that being said, I'm a board certified fellowship trained total joint surgeon at Vail Summit Orthopedics here in Vail and Summit County. And it's with a great honor that we have started to collaborate with Dr. Beam and Alpine Orthopedics in Gunnison and Crested Butte and Telluride in order to bring additional service lines to your community. And overall, my vision for our total joints practice as we continue to expand is to improve patient experience and outcomes through individualized patient care and technology, meaning we are using cutting edge protocols, cutting edge techniques, and cutting edge technologies in order to get patients back on the road to recovery and getting them back out there so that you can enjoy your activities that you love. So, this conversation with Dr. Beam started well over a year ago. And as you can see here, we finally were able to, finalize the merger back, I think, the end of August, early September of 2021. And as you can see, Alpine Orthopedics has a longstanding, excellent reputation. So does Vail Summit Orthopedics. And now combine those together, we now have Vail Summit Orthopedics Alpine in Gunnison, which is a wonderful opportunity. And as you can see here, the new service lines that are now available to our patients in the Gunnison Valley, Crested Butte, and in Telluride includes all of the sports medicine that you've had access to before with Dr. Beam's talents, including both operative and non-operative care. Keep in mind that a lot of the non-operative care available to you for any of these specialties are available to you at VSON Alpine. We now can offer total joint replacements, both primary, complex, and revision surgeries. We'll kind of go into that here in a little bit more detail in just a minute. We also have Dr. Braxton, our neurosurgery partner, that does a lot of minimally invasive spine. We have interventional pain medicine with Dr. Nerke and Dr. Rob that do everything from injections with steroids to biologics to ultrasound treatments, and are a huge asset to our patients. Hand and wrist, shoulder and elbow with Dr. Dorff and Dr. Joseph and Dr. Cunningham, Dr. Sider, Dr. Starrett, foot and ankle with Dr. Elton, minimally invasive surgeries. All of us perform minimally invasive surgeries. We do joint preservation with our arthroscopic practices, the scopes that we do in the shoulder and the hip and the knee, and we cover orthopedic trauma. And then again, the new locations now that we've merged include Gunnison, Crested Butte, Telluride, Buena Vista with our outreach clinic there, Frisco and Summit County from Breckenridge to Silverthorne and everything between, Vail, Edwards, Eagle, and Grand County with our new expansion into Granby as well. So as you can see, we're a growing practice and we're excited to take care of all of our patients. And one thing we want to mention is that with this merger, we now have access to our Vail Summit Orthopedics Foundation in the Gunnison Valley. And this allows us to do cutting edge research, myself included with a number of my other partners. We are publishing multiple publications per year, from basic science research to outcome-based research to case reports to things that are helping move medicine forward, making surgery and orthopedics better for you. We're working with our educational platform. We have athletic training fellows that work with us throughout the year. They learn how to be first assistants in the operating room. They learn to, cover the athletic fields at the high school and the college level. And so they're working closely in your communities with you. Development, myself included, and a number of other surgeons, we're working closely with industry to help develop new technologies to benefit our patients. And we're giving back to our communities by putting additional resources for you into your community. And other thing to keep in mind is with Dr. Beam's, Olympic experience, all of us are U.S. ski team physicians. And so we bring that expertise to your communities as well. And I couldn't give this talk without giving a shout out to John Policandriotis. He's our CEO, our Chief Executive Officer at Vail Summit Orthopedics and Alpine now. And he's really been a visionary for our practice. And with all of our talented partners, we've had this growth vision for quite some time in order to, again, provide excellent orthopedic care to our mountain communities to keep people active. And with John's help, Vail Summit Orthopedics was actually voted to be the 2020 Practice of the Year among the American Association of Orthopedic Executives. So that's a high honor. That includes all orthopedic practices from private practice to hospital-based practices from all over the country. So that's a huge honor that John's been able to achieve for us. So in order to kind of understand what we can bring to the table in Gunnison, I want to go through today's talk with you. And we're going to talk briefly about what adult reconstruction is. Oftentimes I say that to people and they don't know what I'm talking about. So I want to make sure we kind of define that. What arthritis is. There are three major categories of arthritis, and we'll go through those together. We'll talk about a brief history of adult reconstruction, kind of where we started, a century ago and where we are today and how we got here and where we're going. Treatment options for arthritis, both operative and non-operative treatments. We'll discuss some newer advances in surgical treatment and techniques. We're going to review a couple cases, and we're going to conclude by bringing, discussing how we're bringing total joint replacement surgery to Gunnison, specifically outpatient total joints. So adult reconstruction is really an orthopedic subspecialty that focuses on the surgical treatment of painful arthritic hip and knee conditions. It's also known as total joint replacement surgery. And arthritis is really a generic term that describes the process in which the normal joint cartilage breaks down. So if you think about a healthy joint is like a nice Zamboni ice skating rink. It's really nice. It's easy to skate on. It's very smooth. But after 3 periods of playing hockey on the ice, it gets really chewed up. And that's what happens is arthritis goes from this nice, smooth hockey rink. It gets kind of destroyed and rutted out. And it's not very fun. And it gets very painful. And that's because the cartilage is breaking down. It's forming all these ruts and potholes and you name it. And so arthritis is really the process in which cartilage breaks down, resulting in a lot of inflammation, a lot of pain, a lot of swelling, a lot of stiffness, a lot of mechanical symptoms that we describe as clicking and popping, crunching, snapping, those kind of things. And so there are 3 major causes or 3 major categories of arthritis, from an inflammatory arthropathy, which is basically where you can thank your parents for this, typically as you get rheumatoid arthritis or psoriatic arthritis. That's more of a genetic component, but there are some environmental factors as well. The wear and tear arthritis is the most common form of arthritis we see here in the mountains because we're such an active lifestyle. Now, I kind of joke around that we have 2 choices in life. We can sit on the couch and, develop diabetes, or we can be outside exercising and develop arthritis. So we get to pick our poison, so to speak. And most of us living in the mountains enjoy being active, but unfortunately can develop arthritis over time. We call that osteoarthritis. And then there's post-traumatic arthritis. Well, sometimes we're dealt a specific hand that we have to play in life. And, when you have a bad trauma, a bad tibial plateau fracture, a bad, ankle fracture, hip fracture, whatever that is, that can lead to arthritis over time. And it's, that's why we never say it's your last ski run of the day. We always say it's the second to last as you're heading down the mountain. So again, this is kind of a picture of what hip arthritis looks like. So if you look at the left side of your screen, you see a healthy appearing hip joint, nice round femoral head, nice congruent socket, the acetabulum, and nice smooth looking cartilage. As that hip joint starts to break down, we see it start to look pretty rough. It starts to become deformed. We have a lot of osteophytes, those bone spurs that people typically have pain because of. And the cartilage is just broken down and you're trying to rub bone on bone. And that's causing a lot of pain and inflammation and mechanical symptoms. With the knee joint, it's a very similar process. On the left side of the screen, we see a healthy appearing knee joint with healthy cartilage, healthy soft tissue structures. And over time, with any 3 of those prior categories, we can develop these bone spurs, potholes, cartilage debris, damage, and again, lots of pain, stiffness, irritation, inflammation, and that can be very, very uncomfortable. So let's say you have joint pain. Well, what do you do now? Your joints have been hurting for a while. You haven't really had an evaluation, but it's just kind of becoming more annoying. Well, the good news is you can come in now and get a consultation with VSON Orthopedics, both at our Alpine clinic or in our Summit and Eagle County clinics, in order to better kind of understand where we're at. And there are a couple different treatment options, and there's kind of this global option, 2 major global options with arthritis. There's the non-operative treatment, which includes physical therapy and injections and weight loss and anti-inflammatories and activity modifications. And then there's the surgical management, which again, we'll get into in a little bit. But unfortunately, once we develop arthritis, there's no medical cure for arthritis. Okay, so keep that in mind, but there are ways that we can help you avoid surgery. So osteoarthritis and post-traumatic arthritis, the non-operative treatments consist of low-impact aerobic exercises such as swimming, biking, elliptical machines, This maintains a cardiopulmonary health, i.e., example for your lungs and your heart. It helps decrease the painful forces felt across the hip and knee joint, and it keeps your joints moving. Remember, arthritis, once it happens, it's you kind of want to use it or lose it, so to speak. So most people with arthritis, they have this kind of startup pain. It really doesn't feel good after they sit for a while. They get up and walk, and you're like, oh, I got to work this out. But once they start moving, it actually starts to feel better. So with arthritis, we want you to move. We want you to get up and walk. We want you to focus on those low impact exercises. The other thing that can be very helpful is the over-the-counter anti-inflammatories, such as non-steroidal anti-inflammatories, such as Aleve, Advil, ibuprofen, naproxen, Celebrex. These help fight the underlying joint inflammation. So they are pain control, but they're also controlling this pain and swelling, and that's the fundamental mechanism of anti-inflammatories. Some people come in asking for narcotics, and I understand that patients are in a lot of pain, but narcotics really typically just gets us into more trouble. And so we reserve narcotics for after surgery. Narcotics don't treat the inflammation or arthritis, they just mask it. And so a lot of the time with this new concern about narcotic addiction, we don't want to put people on narcotics preoperatively. We want to use them for short courses postoperatively so that we can get you off of them in a matter of just a few weeks after your surgery. So osteoarthritis, again, post-traumatic arthritis, we can use intra-articular joint injections from steroids. That's typically our first-line treatment. A lot of people ask about steroids. Well, doesn't that cause joint damage? Well, at the end of the day, we do know that as long as you get these injections spaced out at least 3 months apart, the risk of progressive joint damage is quite low. If you're getting a lot of injections repetitively into the same joint, back to back to back to back to back, you can cause advancement of your arthritis. So we do recommend for steroid injections no more than probably 4 injections per year or 1 injection every 3 months. With viscose supplementation, which everyone refers to as the rooster juice, these are really kind of like, it's like WD-40. You're kind of oiling up the hinge, so to speak. And this is more of a lubricant, and you're injecting this into the joint. This has been brought into question with a lot of high-level evidence research. Patients do respond to it, but because there's a mixed bag of results, we don't use this as a first-line treatment. We reserve this for patients who may need to trial alternative injections if they're not responding to steroid. You want to maintain a healthy diet. Again, you want to maintain the appropriate nutrition to keep your body mass index in check and keep you active. And the other thing is maintain a healthy weight. Body mass index, as we know, is our height versus our weight. And with that being said, the heavier we are, the more painful forces we feel across the hip and the knee. And so sometimes I know that this is a very emotional conversation. And as we talk about this, it can be very frustrating for patients. But keep in mind that the good news is that for every pound we carry on our body, 3 times that amount of force is felt across the hip with walking, and 4 times that amount of force is felt across the knee with walking. So for a 200-pound man like myself, if I were to lose 5 pounds, my hip would feel like I lost 15 pounds and my knee would feel like I lost 20. So you don't have to lose tons of weight, but just losing a couple pounds can make a world of difference for your joints. So once we've trialed and failed the non-operative treatments, which I always recommend patients do before they commit to surgery, once we've trialed and failed those treatments, we can move on to the surgical management. The good news is that the operative treatments for painful arthritic joints, both hip and knee, have advanced tremendously over the years. So in order to understand where we are today with our total joints and where we're planning on going with total joint replacement surgery, we actually need to quickly review where we came from. It wasn't that long ago that patients with bad knee and hip arthritis were really kind of condemned to a lifetime of disability. 100 years ago, minimal treatments existed for arthritis. Patients were left disabled. And it really wasn't until about the late 1800s where orthopedic surgeons, and actually back then they were just surgeons. Orthopedic surgery as a professional organization didn't exist until after this time. And so surgeons back in 1891 and 1860s were experimenting with artificial joints. In Germany, Dr. Gluck or Professor Gluck was working with ivory. In France in the 1860s, they were working with soft tissue interposition, basically taking fat and putting it in there. In the USA in 1925, Dr. Smith Peterson started working with glass, utilizing glass to replace hips. Interestingly enough, the hip approach that we use today for the anterior hip, which we'll get into, is the Smith-Peterson approach. So the anterior approach, the actual incision we use, was developed back in 1925, which is pretty incredible. Back in Sweden in 1947, they started working with artificial knee replacements, but they were more of a hinge, like what you would see on your door. And those are okay, but still had issues. So moving on, it wasn't until probably the 1960s and 1970s that we started to see the modern day total joint show up. So in England in the 1960s, Dr. Sir John Charnley developed a low friction hip arthroplasty, and he's considered the father of the modern day total hip. And that's where he took a metal femoral head and articulated that on a plastic socket. And that's actually what we use today. But kind of generations of advancement have occurred. In the USA, 1973, Dr. Insall came up with a total condylar prosthesis, and he is considered the father of the modern day total knee. And again, all these fundamentals and teachings and principles are what we're building our foundations off of. It wasn't until really I showed up in Vail in 2015 that we started to bring a lot of newer technologies. I finished my fellowship in 2015 and came up to Vail right after that. And we brought new technologies to the mountains with minimally invasive direct anterior hip replacements and robotic assisted and customized total knee replacements. And we started working with our anesthesia colleagues, our physical therapy colleagues, to really focus on rapid recovery techniques. And we started to evolve our program to incorporate outpatient total joint surgeries very early on, actually. And so really started working again with our outpatient total joints program here in Vail, seriously around 2017, I would say. And that allowed us to develop some protocols early on that are now nationally recognized. And this allowed us to work on our educational platform with working with our patients, our patients' families, their friends, your primary care doctor, your local ER doctors, so that people know that this is how we are taking care of our patients now. Our anesthesia teams are incredible, and they're on board with, short-acting spinal anesthetics and peripheral nerve blocks to keep you comfortable so you can go home very quickly. Rapid recovery physical therapy. We do know that with all of our research over the last 100 years that the patients who get up and walk the fastest are going to do the best. And so our goal is to get you up walking with physical therapy that afternoon after physical therapy. We want you to start walking really within about 2 to 4 hours. Basically, as soon as the spinal has worn off, we want you up walking. An outpatient postoperative physical therapy starts about a day or two later. Pain control. Remember, when I was a kid, my grandmother had both of her knees replaced, and she probably spent a month in the hospital. That's what it seemed like to me when I was 12 years old. It's incredible to see that over my training, we used to keep patients 10 years ago in the hospital for 2, 3, 5 days sometimes before they would go home. And why we did that was really because of pain control and PT. As we figured this out, we've been able to make sure that all the medications you historically would get in the hospital, we're actually going to send home with you now. And so that allows our patients to get home quickly, from narcotics to anti-inflammatories to anti-nausea medications to nerve medications, things that are going to help you stay comfortable. And we approach pain from a multimodal standpoint. So we're not just giving you narcotics, but we're actually trying to control pain through multiple different pathways, from, again, Tylenol, meloxicam, and anti-inflammatory. Some narcotic is important, but we get patients off that pretty quickly. And with the other medications, patients are doing fairly well in a matter of just 2 to 3 weeks as far as getting off of some of the heavier meds. Patients overall still unfortunately do find the first 6 or 8 weeks as being fairly intense. But the good news is that by 6 or 8 weeks out, we expect our patients to be about 80, even 90% recovered. That's much faster than it used to be, where it could take 3 to 6 months before you got to 80 or 90% recovered. The last 10 to 20% of your recovery is all about focusing on your long-term goals, reintroducing your athletics, focusing on getting back to sports. And that can take up to a year to kind of dial in some of those things. But the bulk of your recovery is going to be behind you once you get to that 2-month mark. And So with our outpatient rapid recovery total joint program, again, both total hip and total and partial knee replacements, we're using anterior total hips with computer navigation or rapid recovery protocols. This is covered by all insurance carriers. And again, over 90% of our patients are safely discharging home within 24 hours. And actually, it's more like 6 or 8 hours these days. Total knee replacements are very similar, minimally invasive technique, robotic assisted, customized implants, personalized implants, rapid recovery. And again, just like our hip patients, we're seeing them discharge within 6 or 8 hours after surgery, and over 90% are leaving within 24 hours, which is still considered outpatient. So the reason why this is important is because COVID occurred in 2020. And as a lot of us have seen nationally, COVID has created a lot of healthcare crises around us. It seems to be somewhat interesting because I came into this practice in 2015, and we started kind of dabbling with outpatient total joints and kind of got our act together before we had to make decisions. But when COVID happened and the hospitals started shutting down, we had these safety protocols in place, and we're able to safely pivot and transition to do most of our elective patients at our outpatient surgery center, where the risk of COVID and exposure is excessively low. And so that's really good. And the nice thing about, honestly, COVID too, is it helped get our insurance carriers on board with all of this as well. So even Medicare allows us to do outpatient total joints. We also know that, again, 90 to 95% of our patients are safely discharging home 6 or 8 hours after their surgery. And outpatient total joints at the surgery center are a more cost-effective and safe choice for the right patient. And so keep that in mind, that it actually is less cost burdensome on the healthcare system. So it is a good alternative. So again, in order to kind of, kind of help us understand where we are with our total joints, let's kind of review a couple cases. This is a total hip case that we did at our surgery center. This is a 64-year-old female. What you're looking at in the top right corner of your screen is what we call an anterior posterior pelvis x-ray. So we're seeing the pelvis, and we're seeing both the right and the left hip. Keep in mind that as you are looking at these x-rays, you're looking at them as if you're looking at the person head on, looking at their face. And so the left side is going to be on your right side. Okay, so the left side is the side that shows a lot of bony destruction in the top right corner of your screen. And with that being said, she had severe left hip osteoarthritis, a lot of bony destruction, cystic changes, and she was functionally debilitated with this hip. She couldn't even walk with it. We did an outpatient total hip replacement, direct anterior approach. We used our computer navigation systems, and she discharged home 6 hours after her surgery. At 6 weeks post-op, she was already reporting a 90% recovery. She was walking unassisted. She was working on her strength and balance and coordination, and she was off of all the medications we gave her. And in fact, she was so happy. She was very emotional in clinic and just couldn't believe the new lease on life that she was given. She was so thankful. As we look at these new hip implants, this is what we use actually. So DePuy Synthes is our total hip carrier, or total hip company. They're a Johnson & Johnson based company, but their hip replacement stem, I think, is one of their best, one of the best out there. And their bearing, which is the ceramic head and the plastic liner, what we call a hard-on soft bearing, is the best option we have in 2021. As we know, total joint replacement surgery 15 years ago when I was in my residency kind of became got a bad rap with metal on metal hip replacements. We've all heard about this, I suspect, at this point, where hip recalls were happening, people were having more surgery because of bad implants, all these things, so on. And what we've learned as an orthopedic community is the metal on metal hip replacements and hip resurfacings are found to be too dangerous at this point in time. So we no longer use metal on metal hip replacements. What we did was we went back to the drawing board to Dr. Charnley's recommendations back in the 1960s about using a metal head on a plastic liner. And with that being said, we took it one step forward, and we found that the ceramic heads that we use provide significant strength and minimal polyethylene wear with our newer polyethylene technologies. And so with that being said, it's a long convoluted story to say with our new ceramic heads and plastic liners, the wear patterns are very, very low, meaning that these hips have the potential of lasting a very, very long time. But as you can see, with all this technology, we're moving surgery away from an artistic surgery, because that's what total joint surgery is. It's really a soft tissue balancing surgery. We're moving away from an artistic surgery and turning it into more scientific. And this allows us to improve the accuracy of your joint replacement and improve your early rapid recovery and long-term success with additional decreased soft tissue trauma. And the nice thing about it is it allows me, to do a more reproducible total joint replacement. Historically, about 10% of hip replacement patients report some kind of dissatisfaction with chronic pain or leg length discrepancy or hip dislocations. All these things are really frustrating for patients when those occur. The good news is, with our newer technologies and techniques, we actually see that our patients at 1 year out are reporting a 98% chance of doing so well they forget they've had a hip replacement. There is a 1 or 2% chance where you could have some achiness with exercise or so on, but it's better than typically what you have. And then all the terrible things that we talk about, such as infections and failures and dislocations and bones breaking and all that stuff, all of that adds up to happen less than 1% of the time. So in reality, we spend a lot of time talking about the 1%, but you really have a 99% chance of doing very, very well and being very, very happy. If we look at how we do knees today as well, we've modernized the knee replacement. Outpatient total knee replacement surgery is here to stay, as well as the hip. And as you can see in this x-ray series, on the left side of your screen, we see a long leg x-ray of an arthritic knee joint, right knee. It's bone on bone. We have some subluxation of the joint where the bones are no longer lining up. And with that being said, this is a 69-year-old male with severe debilitating right knee pain. Was able to do a lot of activities, but just became more and more uncomfortable with this. He trialed a lot of injections and physical therapy for a long time, and he finally just had enough with it. He was ready to move on. And that's typically what we hear with our patients as they start to kind of go down this pathway. I recommend people live with their joints as long as they can, but at some point in time, you're going to come to a decision on your own that something else needs to be done. And when you get to that point, that's when you contact Dr. Beam or myself. But with this patient, we move forward with a same-day outpatient robotic-assisted right total knee arthroplasty, minimally invasive. And what we see in the middle x-ray is that long leg x-ray where we did a total knee replacement. And on the other two views, we see a lateral view and a patellofemoral view. So with the kneecap, remember, a knee joint is actually made up of 3 different compartments: the medial, the inner side of the femoral and tibial compartment, the lateral side or the outside, but also what we call the patellofemoral compartment, how the kneecap tracks along the anterior femur. And with that being said, we typically resurface all the parts, specifically when they're very arthritic. And so with that being said, we did a robotics-assisted total knee replacement. He discharged home about 10 hours after surgery. At 6 weeks post-op, he was reporting an 80% recovery. His knee range of motion was normal. He was walking normal unassisted, and he was working on strength, balance, and coordination as long-term goals of getting back to skiing. And one of the fun things about living in the mountains with our patients is that we get to do things with our patients. And I was actually able to ski with this gentleman at 6 months after surgery, and he was very, very happy. The other thing that we can offer is partial knee replacements. Now, we see more total knee candidates, meaning more patients with the knee completely arthritic. And we see probably 10% of our patients are candidates for partial knee replacements. There are pros and cons, and there's right decisions and not right decisions to have either or. And my job is to help work with you if I feel you're a candidate for more of a joint preserving partial knee replacement to offer that to you. But it's a conversation we have together. But this is a 37-year-old male. He's a ski racer, lots of ski trauma to the knee, prior ACL reconstruction. Just kind of had worsening medial sided left knee pain. I apologize, I don't have a preoperative x-ray, but when you're 37 years old and you're bone on bone on the inside aspect of your knee, it's very, very frustrating. And with that being said, he wants to get back to ski racing. And so in order to try and salvage someone's knee, we can talk about doing osteotomies where we correct their alignment through bony corrections and so on. But really what this 37-year-old male needed was a partial knee replacement. And so we went forward and I performed a partial knee replacement. This gentleman I just did about 2 weeks ago, and he was able to go home right after surgery, and we just saw him at his 2-week visit, and he's doing really, really well. So we have options to do more joint preserving knee replacements, but again, it's not necessarily an option for everyone, but if you are a candidate for it, I'll let you know. So overall, the newer technologies that we're seeing in knee replacement and hip replacement surgery include technology, they include implants. And what this allows us to do is we're moving away from the art of surgery and we're turning it into more scientific technique. So again, this allows us to minimize soft tissue trauma. It makes the surgery more reproducible case to case. With knee replacement surgeries in general, historically and nationally, we see that about 20% of patients are reporting some kind of dissatisfaction with a knee replacement, whether it's most commonly it's some kind of chronic pain. Other things like stiffness can be an issue as well. But with all this technology, we're seeing that 20% of patients with lingering pain can be much smaller. And in our practice, we're seeing our patients report a 95% satisfaction rate at 1 year out. They probably have a 4 or 5% chance of doing good with the knee replacement. Maybe it does ache a little bit with exercise or athletics. Maybe it swells a little bit longer or more than you want it to. Or maybe it's just a little bit stiffer than you want it to be. But typically it's still better than what you have before you have surgery. And then again, all the scary, terrible things that I tell you before surgery, the good news is all those things happen less than 1% of the time. So very, very low that something unfortunate happens. There are newer technologies from our Zimmer Beim at Rosa robot, conformist custom-made implants. And my job, and Dr. Beam's job, is to sift through all this stuff so we can provide you with the best options we have today. That's just a picture of me getting ready to perform surgery. So last few questions. Dr. Beam and I are very, very excited about offering total joint replacement surgery to our Gunnison community. And so the questions are really, when should you consider joint replacement surgery? Well, it's really a complex decision between you and your surgeon. You want to try and exhaust all the non-operative treatments first. You want to, but typically your body will let you know when it's time to consider this. And that's where I come in and Dr. Beam comes in, and we are here to help you get where you want to go. So the other question we often hear is how or what kind of activities can you get back to doing after joint replacements? Well, what we do know is with our newer technologies, our newer implants, patients are able to get back to a more reproducible, wonderful quality of life. So with that being said, once you heal this up, if you were able to do something before surgery, my goal is to get you back to doing that after surgery. I'm not sure I would recommend you learn how to run ultra marathons after your knee replacement. But if you're a big time skier and you're a big time golfer and you're a big time mountain biker and cyclist and all these other things, we want you to get back to that. And a lot of patients will. While any activity is safe, we still do encourage some lower impact athletics. I think the higher impact athletics historically have gotten knee and hip replacement patients into trouble. But again, with our newer technologies, that's less of an issue. But we still recommend avoid long distance running for exercise or aggressive court sports, specifically where you're cutting aggressively. And that can cause wear and tear arthritis. Remember, these are, not wear and tear arthritis, but these can cause wear and tear issues with the metal and plastic. And with that being said, think of a joint replacement like the brake pads on your car. The harder you push it, the harder you drive it, the faster it could wear out and the faster you may need new parts. And so with that being said, once you get a joint replacement, heal up, live your life, enjoy it, but just keep in mind that the harder you push it, the faster it could wear out over time. So with Dr. Beam's vision and with a lot of collaboration, we're excited to bring our world-class orthopedic care closer to home. And with that being said, Dr. Beam and I are working closely in order to build our joints program in the Gunnison Valley, wanting to provide this care to Crested View, Gunnison, the surrounding communities, in order to allow us to provide you localized care so you don't have to travel over the pass anymore. We want you to work, but unfortunately we have some work to do still, and that's where we are still working on our infrastructure. Right now, Alpine Surgery Center is nicely dialed in to do total knee replacements and partial knee replacements. So that's what we're going to focus our energies on right now. Our future goal is to eventually provide anterior total hips, but that's another level of complexity that we have to kind of work towards. And so right now we're providing knee replacement surgery services. Both Dr. Beam and I and our new partner, Dr. Lindsay, can do all the primary total joints at the Alpine Surgery Center. And more complex cases and potentially revision cases do still need to travel to the hospital, but we will help you figure that out and navigate that with you. Other things we're working on a lot for me personally is transportation. How am I getting down to Gunnison reliably? Whether, is weather going to affect that and all these other things? Where would I, what kind of housing options we have? Unfortunately, insurance is part of this discussion, and we are working with your insurance carriers in order to make sure we can provide this quality of care locally as well. We are well into those conversations, and hopefully we'll have a lot of answers very, very soon. And again, we're working with industry. We want to make sure this is a cost-effective approach. Implant companies are very, very good, but just like anything, they are interested in the cost of their implants, and so are we, and we want to minimize the cost as much as we can. So those are the negotiations we're doing right now in order to help bring the service line to your communities. But again, the things that require, the surgeries that require higher level of care are the revisions, infections, and some complex and conversion cases where we go from prior surgeries to total knee replacements or total hip replacements. Sometimes those still need to be done at the hospital. So overall, total joint replacement surgery is better than ever. Patients are getting back to an awesome quality of life faster and sooner with our rapid recovery protocols and our anesthetics and our physical therapy and our pain modalities. The newer techniques and technologies that we're using and that we're bringing to the Gunnison Valley allow us to provide minimally invasive joint replacement surgeries. We're improving and customizing your joint replacement, and we're moving, again, away from artistic surgery to more of a scientific approach that allows us to improve your outcome. And remember, orthopedic surgery is a team approach. This is a team sport, and with all of us working together, Dr. Beam and myself and our partners and you as our patients and our community, we take care of you to meet your needs. And keep in mind that Dr. Beam has a wonderful history of taking care of her patients locally. We want to honor that. We want to keep you locally. And we can take care of your needs from the preoperative, non-operative management to the post-surgical management. Even if I'm traveling back and forth to do these surgeries, Dr. Beam, Dr. Lindsay, and myself are motivated to prevent or help you minimize how much traveling you have to do. And again, our overall goal is to bring world-class total joint care closer to home in Gunnison. So anyway, that's really it. It's been a pleasure to talk to all of you. Again, I'm Dr. Nathan Caferkey, and I wanted to say thank you to Dr. Beam for all of her vision and all of her expertise and all the years of providing excellent care for our communities there locally in the Gunnison Valley.